I'd like to now invite Drs. Gary Lemmon and Jens Jorgensen from the VQI to give an update on the VQI and getting trainees involved. Welcome, gentlemen.
Thanks very much. And I'd like to thank Dr. Shames and the APDBS for a little bit of time on the program this morning. And it seems to be particularly appropriate that we follow the presentation to Dr. Cronenwet, because as I think you all know, he was really the founder of the VQI. And we started working on it back in 2003, back in northern New England. And so what I'd like to tell you is a little bit about our mission, the overall overview of VQI, what we've been up to recently, our plans for the future, and most significant for this group is how we hope to get trainees involved more in VQI. The mission of VQI is to improve the quality, safety, and effectiveness of vascular health care, and in short, use data to improve the care that we provide to our patients. VQI, since its inception as an outgrowth of the New England group, has had a steady increase in participation. We have now almost 800 centers over the US and Canada. VQI really has three components: our 14 registries, our regional quality improvement groups, and our collaboration with our commercial vendor, MedStreaming M2S, who is responsible for data collection, reporting, archiving, and so on. We now have over 750,000 procedures in the registry. The procedures cover the full spectrum of arterial and venous disease, adding over 10,000 procedures per month. And we are now very pleased to announce that we, in addition to our procedural-based registries, we now have a vascular medicine registry, and also last year we released a venous stent registry. You can see that the PVI and carotid are the busiest registries, but almost all of them have over 10,000 cases. One thing that we did learn over the past year is that the best time to release a new registry is not during a pandemic. One of the unique aspects of our registry is the regional quality improvement groups that meet biannually to discuss outcomes, quality improvement projects, and really learn from each other. Have been a very significant part of what we are. One of the aspects of VQI is that even though we're based within the Society for Vascular Surgery, less than half of our participants are vascular surgeons. We have good representation from cardiology, radiology, and specialties. And in addition, about 1/3 of our hospitals are academic, 1/3 are teaching hospitals, and 1/3 are community centers. So we real that can provide real evidence for this meeting. There we go. Oops. Can you back me up one, Pete?
Stand by.
Yeah, there we go. One forward. We are a very collaborative organization, and we try to develop collegial relationships with other professional societies, including the American Venous Forum, Society for Vascular Medicine, Vascular Access Society, American Heart Association, and Society for Vascular Ultrasound. Last year, after almost 2 years of negotiation, we were able to establish a very good relationship with the American College of Cardiology, NCDR, PVI. Let's see, I'm having a little trouble. It may be my internet.
You want to say next slide? I can advance for you.
Okay, back us up one, please, Pete. Okay, then forward one. So the SVS is working with the ACC NCDR. They are going to be closing their registry, and the ACC NCDR representation and will be co-branding. The NCDR PVI registry closed at the end of last year, and now they're encouraging centers to join us and enter their data as of January of this year. Forward. Okay, so as mentioned, they're shutting down as of last year, and encouraging setters to join us and enter data now. Next slide, please. The VQI is organized under the auspices of a patient safety organization, so informed consent is not required. It protects any data or work product from legal discovery and precludes comparative data to be used for marketing. Next. These are the 13 registries that we have in place, again covering the full spectrum of arterial and venous disease, including our disease-based registry, vascular medicine. Next slide. We're very excited about this vascular medicine registry because it's kind of unique in the registry world to be collecting non-procedures. We did this in collaboration with the American Heart Association and Society for Vascular Medicine, and we'll be collecting data on patients with carotid stenosis, lower extremity occlusive disease, and abdominal aortic aneurysm who are managed non-operatively, which allows us to look at the impact of medical management, tobacco cessation, and exercise program. And we really think we're going to learn a lot from this registry. Next. Some of the benefits of VQI participation include that one of our other unique aspects is we have 1-year follow-up, and we can link to Medicare claims data for even long follow-up. As mentioned, we have real-world data, including participation of academic and community centers. Our granular data includes device identification, and importantly, for many of you, as you found out, it allows reimbursement and coverage if you're doing TCAR procedures. Next slide. It also allows us to use the data to look at real-world problems. We've used VQI analyses to look at the paclitaxel outcomes because we're one of the few registries that include unique device identifiers that allows us to look at paclitaxel devices. And over the past year, we've used VQI data to look at the impact of the COVID-19 pandemic. Next slide. These are some quality improvement initiatives, discharge medications, patching, ultrasound guidance, and so on. Next slide. And it's really important part of what we do. We support QI efforts. We have a director of quality. We have a project guide. Next slide. We have a lot of resources, including Cheryl Jackson, our director of quality, the regional meetings, webinars, newsletter, and so on. A lot of support for anyone, any center that wants to do quality improvement. Next slide. Over the past year, we've had 55 new quality charters, again, looking at things like discharge medications, length of stay, and readmissions. So we really feel this provides value to the participating centers. Next slide. And I think, as you're all aware, it's a robust source of data for analysis and publications, over 100 in the last year, and almost every JVS issue has 5 or 6 articles based upon VQI data. Next slide. VQI is very committed to DEI, so we formed a DEI committee. Our chair is Lila Maribi, and as part of that, we want to hear the voices of younger generation trainees and younger surgeons. And so now next slide. We're going to be working hard to get trainees more engaged. And so at this point, I'll pause to take any questions before turning it over to Gary Lemmon, the Associate Medical Director, for further discussion about our trainee program.
Dr. Shames, I'm not sure if you want to take questions at this point or move forward.
I don't have any questions right now. I mean, I think everyone's pretty familiar with VQI and its impact that it's had on quality. You know, I think what we'd like to hear about is how we could get our residents involved in QI and how we could get more engaged with research and opportunities. So why doesn't Gary hop on, and then we'll see if there's some questions get generated.
Take it away, Dr. Lemmon.
Thank you, Pete. Good morning, everyone. You can see the screen up there, and in concert with the SVS mentorship program, we decided from the VQI leadership to embark upon a trainee program as a mentorship model. The purpose is to engage our 0 to 5 residents and our 5 to 2 fellows into an understanding of the quality process and the research that's embedded within the VQI. For this purpose, we would select appropriate trainees to be nominated through the local regional groups, a total of 18 regional groups. They would be then selected to find or appropriate a mentor, hopefully from the regional medical director or the regional associate medical director, to attend regional meetings. This would be a 1-year commitment for the trainees. The option is to continue ongoing until the completion of their training. The attendee would certainly participate in the development and implementation of the meeting, including reviewing the comparative data at each meeting. From a local center perspective, we would invite them to engage into a quality improvement project, which could entail something as simple as improving long-term follow-up, or from a regional perspective, improving regional reports for EVAR sac diameter reporting. So there are many options for that. The mentorship would include participation in potential memberships, including our regional meetings for research, as well as the quality committees from arterial and venous centers for that. We would continue to engage them and encourage presentations of these projects both at the regional meeting and, if selected, then potentially to present that information at VQI at VAM. The mentorship could include also engagement with the leadership within the PSO. Next slide. So from the quality improvement mentorship program, initially we ask that they develop a local quality improvement initiative, such as improving discharge medications, long-term follow-up, all those that Jens mentioned before, the quality programs that we have undertaken, and to then submit an abstract for possible both local and regional and national involvement from that. We would envision a 2-tiered system for this. The first year and subsequent years would be into the involvement in the regional meetings and understanding the nuances of group dynamics in the regional presentations. And then individuals from that would be selected possibly in their later years to participate in a second tier level, which would involve direct engagement with the leadership of the PSO, both in the analytical front and participation in additional meetings. We are working at this time to consider a scholarship program for that second tier process. But this is a overview of the program. I'll be happy to take any questions as you have from this. We think we're really excited about having resident and fellow participation, and at least for the first year, we'll hold off on allowing medical students to participate, but the long-term model is to also engage medical students in for this.
Thanks, Gary. That was great. So there's a couple of questions. Please put your questions in the Q&A rather than the chat. But some of the questions that have come up is, I guess, to really define the process and who selects the trainees. Can the APDVS or an APDVS representative be engaged or participate in that process? And you know how do we actually get them directed to do this? Who do we reach out to? Can you guys provide some contacts, or who do we reach out to get our residents involved?
Good questions, and we'd certainly like to work with the APDVS in selecting these candidates for that. They would essentially be chosen through the PSO as well, but we would arrange for also members who are in agreement to become mentors for these residents and fellows within each one of the regional groups. So it would be a collaborative event from that.
And so you guys commented in the chat, but the ACGME is beginning to ask about trainee outcomes. Can the VQI consider a drop down that would perhaps say R1, R2, R3, R4, or whatever, so that we could give them outcomes data for themselves? I think that's going to be important going forward, that the residents actually know what their outcomes are. I see Jens has responded, but is there a timeline on that, or how do we get that information?
Jens, you want to field that?
Sure. Yeah, you can add some customized fields so that the resident themselves can actually be named within that. And, you know, as I also mentioned in the chat, we're working on incorporating some variables so to define their role, whether the first assistant, primary surgeon, or teaching assistant. So the timeline on that is a little bit more unclear.
That's great news. Are there any other questions? Please put them in the chat. Thank you both. We will, I think we're very excited. Our group obviously wants to continue to participate in quality improvement, and getting the residents involved, I think, is critical. It's part of our metrics. It's part of our RSC requirements and the ACGME requirements. So thank you for all of that.